Ben speaking.
Hi, Ben. This is Ganesh Guru from the University of Maryland, Baltimore County.
Hi, how are you?
Good, how are you? And I have Ili Zhang, who is our PhD student with me.
Hello, Ben. This is Ili.
Hi, Eli.
How are you?
Nice to speak to you guys.
Yeah.
So thanks for participating in our interview study. So the purpose is basically to collect rich contextual data, and we would appreciate if you could give us detailed information. And this is approved by the Institutional Review Board, IRB of UMBC, as basically presenting minimal risk. This is not an interview in, of course, child psychology. We don't expect questions to give you any trouble, but feel free to skip if there is anything. So to start with, what is your role in the department and how is it related to health data? Could you tell us?
Sure. So I am a health policy analyst, and I work in the policy and compliance department here, and we're tasked with sort of a variety of projects, but a big part of what we work on is compliance with federal and state rules. So we have federal audits that we have to respond to ensure that we're paying our claims correctly and enrolling our providers correctly. And that includes the use of a large amount of provider and recipient data, everything from demographic information, type of provider, type of enrollment on the recipient side, who's receiving care and their eligibility with Medicaid. I also work on an eligibility-related program that provides temporary eligibility and a path to full eligibility. It's called Hospital Presumptive Eligibility, HPE, and that's a program it's a somewhat smaller program that's where hospitals can sign up recipients who show up at the hospital who don't have Medicaid coverage, but they can sign them up temporarily, assuming they meet certain criteria. So that requires the hospital personnel to have a basic understanding of what kind of data elements need to be captured, like income and family size, and as well as some other data elements like current enrollment status and things like that, current insurance status. So, and then finally, I work on our telehealth program.
Great.
Which requires us to, we capture information from providers who want to participate in who want to bill for telehealth services, either as a distant or originating site, using sort of, like a two-way audio-video visit, like a Skype type of service. So we require providers to register with us for that, and we check certain data elements against their enrollment status to make sure that they're qualified, because we only allow certain provider types to do that, and only for certain services. So that's a summary of position.
Well, thanks for the detailed answer. So you deal with a lot of data, and so in this interview we talk about the quality of data, and so we use this term called data defect to refer to a discrepancy between the actual and expected state of a data item. So to start with, could you give us an example of a data defect from your context, perhaps something that was striking or maybe costed a lot of money or took a long time?
Yeah, let me think of an example that would be useful. So a while back, we have a vendor that does utilization control for us. So basically, it previously was a different vendor than we have now, but they are tasked with looking at certain services and determining whether they are payable. bad data that involved services for undocumented aliens. So that's a specific coverage group in Medicaid, because federal rules prohibit us from prohibit Medicaid from paying for most services to undocumented aliens. Basically, we're allowed to pay for emergency services only. Some exceptions, I think, maybe renal dialysis is an exception, but on the whole, if you're an undocumented alien, then you're not allowed to receive services through the Medicaid program. But for emergency services are an exception. So we had this vendor who was tasked with capturing information on a bunch of services rendered to undocumented immigrants, and they didn't give us good information. So they might have captured. So each provider, in this case, hospital, has some identifying information, right? They have a Medicaid ID number, which is 9 digits. It's basically it's 7 base digits and then a 2-digit suffix, which is basically, the 2-digit suffix determines which location they are. So you may have a doctor's office that has 5 locations, and so they would have the same base number, 7-digit base number, and then 5, 01, 02, 03, 04, 05 for their different locations. And it's the same for hospitals. And sometimes when those provider numbers get reported to us, sometimes they're missing leading zeros. Sometimes they report the base number but not the suffix. Sometimes there are typos. There could be a whole host of issues, and I mean that's just one data element, right? But it's an important one because it's what we use to identify which hospital we're talking about, where the patient was served. We received a list, and this was when this vendor was sort of toward the end of its contract. We didn't end up renewing their contract for a bunch of services that we pay them basically based on the number of reviews that they do. So they take a look at a series of services provided to undocumented aliens, and then have to determine whether it was payable or not. But they sent our program staff some really insufficient data. They didn't control for the number of digits. There were typos. There were entries where the name of the hospital didn't match the provider number, or where they just said, as an example, University of Maryland instead of University of Maryland Midtown Campus, University of Maryland Downtown Campus, University of Maryland Charles Regional Medical Center. There are numerous University of Maryland hospitals, and they might not have specified. Same with Johns Hopkins. So they weren't sending us data with good integrity, and our program staff didn't do the oversight that they should have been doing to ensure that those services that they were sending us that they did were actually done properly. So we basically had to go through. I had to go through several hundred lines of these reported services and sort of determine which ones were clear enough that we should pay for and which ones were ambiguous enough that we should not pay for, and take it back to the hospital or take it back to the vendor and say, hey, if you can't clarify this for us, then we're not going to pay for it. So that's an example of how not doing good data oversight kind of led to a lot of extra work, and it actually wasn't a terrible outcome for the state because we ended up saving some money, probably tens of thousands of dollars, I think, in terms of what we didn't pay to them. But the reason that we had to do it was because the data integrity wasn't there. Does that
Sure.
Is that helpful?
Yes, so thanks for the specific example. I'm sure over years you've seen a number of examples of these problems. So in general, through which mechanisms and how do you realize or get to know about data quality problems?
Well, it depends on the specific problem, and I mean, I'm not someone who works with it as as intensively as our system staff that does the programming, or someone like David Wertheimer who really works intensively on data governance. But sometimes it will come up because of issues with claims. For instance, claims are being claims get denied, and a provider calls us because their claims are being denied, and it turns out there's a problem with how we're governing their data, but we haven't. But they haven't. We maybe have made a change with the data requirements, but the providers, the data that we have on file for the provider hasn't been updated yet. So we have a whole bunch of data elements that we capture in a provider's file. For instance, in addition to the provider number, we capture their categories of service, so what types of service they're allowed to render. If a provider can be suspended from the program for not responding to a request, or for not providing an updated license or something like that, or for changing their address and not telling us. So sometimes if we start to use a data element that we hadn't used previously in terms of in determining whether or not to pay a claim, then that's one way that it could come to our attention.
Yes. So generally, would it be accurate to say that if the operations are affected because of the data quality issues, you get to know about them?
Yes, that's certainly true. I mean, one thing we're working on right now is, and this may address some of your other questions more so than this one that you're asking about, but newer federal rules require us to enroll more individual providers than we have in the past. For instance, if you were to go to a hospital and receive a service, the hospital would be enrolled with Maryland Medicaid. But previously, the attending physician who's in charge of your care wouldn't necessarily have had to have been enrolled. But that's different now. That's changed. Under federal law now, we have to enroll the attending physician as well as the hospital.
Okay.
So that means that we have to capture that attending physician's information, their NPI, specifically on the claim. So we have to enroll these people, and then we have to also set up system edits in our payment system to ensure that they are not only checking to see that provider is reported on the claim, but also that they're enrolled with us, and that they're the correct type of provider, like that they're a physician and that they're an individual, not a group practice, because only an individual can be an attending provider. So that's the kind of stuff that has been coming up on the federal audit that I work on pretty regularly. So sometimes it'll come to our attention from the provider themselves, because they'll say, hey, my claims are being denied. I haven't changed anything that I've done. What's going on? And hopefully they would have received communication from us about a policy change, but sometimes they don't know about it. And then we can also find out about it through an audit, where CMS will come to us and say, hey, we're checking that you're in compliance with these rules, and they're rules that we've never had to be in compliance with before, and it takes a long time to update our system to get into compliance with them. And so
Mm-hmm.
Those are some ways we might find out about shortcomings with data.
Mm-hmm. Oh, that's interesting. So an external party does the audit, which can actually invoke this maybe exploration
Right.
into data about what's wrong with the data.
Yeah, or just what's not being reported. Right. So it's the federal government that does the audit, or their contractor, and they'll look at claim and say, you didn't properly enroll this provider in this individual provider, and so this claim, you have to give the money back. So
Yes.
that's and that's not necessarily, that doesn't necessarily come from having bad data always, but it comes from having missing data. And just to give a little bit more of a specific example about that. I mentioned the attending provider, the individual attending provider on a hospital claim, for instance, right? So for some types of providers, we have paid the claim even if they haven't reported the individual attending provider, and they would just put the NPI of the facility in that attending provider field when they're billing.
Yeah.
And in the past, we've accepted that. It's not correct because it's not the attending provider. We just tell them, put it there because that will make the claim go through. Now we have to change that. So when you're going into, if you're someone like me who the auditor comes to and says, hey, please provide, we see that this provider here is listed as the attending provider on this claim. So who's that attending provider? Well, I can go in and look up the attending provider NPI, and it'll just say the name of the hospital or the name of the whatever facility it is. And so I won't actually know in that case, I won't even know who the attending provider was. I couldn't even check to see if they were enrolled if I wanted to, because we haven't captured that data because they're billing by just putting, a provider in that field that isn't really answering what the field is asking for.
Yeah. So
that makes sense.
Sure. Yeah. Definitely missing data or the data that is put there just as a replacement is one of the, it falls into our defect categories. Actually, Gili, who sat with me, she actually conducted a semester-long literature review about defect taxonomies and defect categories for data. So I think it falls into that. In healthcare organizations, we talk about quality improvement and continuous quality improvement. So that's basically the quality of healthcare services. So similar to that, if we think about data quality and continuous improvement of data quality, which is about identifying the problems, data defects, and tracking them to their resolution to ensure that they are corrected. So if we think about this data quality improvement, to what extent do you think it is necessary, and why would your organization need it?
Well, I think it's very important in terms of our ability and the ability for our programs to capture good data about what services are actually being paid for. Because if we don't have data elements available to us to show what services are actually being paid for to whom, then it's very hard to do any kind of real analysis on how effective the outcomes are. That's not an area that I have a lot of expertise in. That's because that stuff is looked at more closely by the specific program staff. So the folks who work in the acute care administration or work in the behavioral health unit would have more detailed, more granular understanding of what kind of health outcomes actually result from services we pay for. But I can tell you that from my perspective, working here for a couple of years, that there are certainly areas where it would be nice to know exactly what example of that. We don't
Mm-hmm.
currently really have a good understanding, and because we don't capture that much information about providers who are signing up to do telehealth, so we don't really know. We don't have like great data available as far as which services are being used to what extent. We can do data polls, sort of, we call them ad hocs, one-off data polls to see, what providers are billing for.
Mm-hmm.
But a provider doesn't necessarily, if a provider doesn't put the right indicator on a claim or, or hasn't reported to us who their telehealth partner is, then we wouldn't know where to, we could do some matching to see what recipients are receiving services, but it's not readily available to us. So that's something that would be,
Okay. Yeah.
that there are certain, it's not, you don't have to look very far to see sort of the results of not capturing good data.
Mm-hmm.
It's certainly a problem.
So the operations of the MDH might be affected by the bad data, and in the field, what are the most time-consuming problems that can occur because of bad data?
Well, you might have to, like the first example I gave, you might have to spend a lot of time scrubbing data and sort of, going through. If you have bad data, you might have to go through certain data sets that could be tens of thousands of lines. You might have to go through them line by line to sort out a field. We're, like the audit I mentioned that I work on previously, the name of that audit, by the way, is the payment error rate measurement audit.
Mm-hmm.
In case that's relevant. It's one of CMS's big audits where they look at, every 3 years they look at a sample of state claims. So we're required to screen all of our providers against certain federal databases to show that they don't have records, a criminal record or a record of waste, fraud, and abuse, and things like that, or that they're not prohibited somehow from receiving federal funds through the Medicaid program. So we have to check those databases, and we have to check against the provider's name and tax ID in certain circumstances, NPI in certain circumstances. So we're in the process now of rolling out a whole new provider enrollment system that does the screening, that automates those screenings. It's one of the reasons why we're moving from a paper-based enrollment system to an online web portal. We've contracted a group that has built this system for us, and it does these required federal screenings automatically. So in order for those screenings to be effective, the name field has to be correct, right?
Mm-hmm.
They got to check against the right provider's name. They got to check against the right provider's info. So if it's not correct, then the screening doesn't do any good. So in our MMIS system, the system that governs most of our Medicaid data, and where providers' files are kept, there hasn't really been any standard practice when it comes to how the name field is generated. It's an old system, only has one name field. It doesn't have a first and last name, middle initial. So some providers are in there as, Dr. Yuli Jang, or some providers are in there as just Yuli Jang, MD. There would be, there's no standard way of doing it. And our provider enrollment team, going back however long, decades, has, I think, just never standardized that process. So now we have to come up with a way of going through these hundreds of thousands of providers to try to separate out the name field so that we know, what's the first name, what's the last name. Is there a prefix we can drop things like that. And since there's no consistency to the data, I mean, if it was all, if it was all the same and the spaces were all in the same place, then we might be able to come up with a formula to deal with it. But that's a major problem that I'm not working on myself, but I know that our team is working on with our vendor, because it's and that's a product of having not invested the time and the sort of the coming up with a standardized process for a very basic data field.
Mm-hmm. Speaking of Ili, so she's sitting next to me. I realized that she hasn't asked questions, so I just leave it the next ones to her. Okay.
Yeah. Thank you, Ben. So when the time-consuming issues come to money cost, what are the most costly issues occurring because of data quality problems?
I don't really feel qualified to answer that. I don't know. I would say, as far as time goes, the issue that I just mentioned is a good example.
So is there any?
As far as cost goes, I think that there's certainly audit risks. I think the audit risks that come from not capturing data in a way that is required. That can be hundreds of thousands of dollars, not more. And certainly, my guess would be, I don't know this for a fact, but my guess would be it would be from paying claims that shouldn't be paid. If you don't have good data, if you could end up paying for the same service twice, you could end up, paying for a service that was authorized that shouldn't have been authorized, and that all can add up to a lot of cost, especially if it's a long-term care type of service, or if they're someone is meeting level of care for a nursing facility service, but they really shouldn't be, or someone's in a chronic hospital, but they should be in a community-based setting. That stuff is hugely costly, and the only and that's why we pay vendors a large amount of money to do those types of levels of care reviews, because if you're paying for services that aren't medically necessary or aren't, certainly services that aren't medically necessary, but then there's, and also just, if you don't have a good way of tracking data, then you're going to end up paying for stuff you shouldn't pay for. Like, you could pay a fraudulent provider, or you could, pay for a service twice or something like that. And I think, we do have, pretty good system edits in place to prevent a lot of that from happening, but it's still possible for providers to find a way around it. We have an old system.
So are there any estimates that you have heard about, let's say, fraud, waste, and abuse? Did anybody look into that in MDH? In terms of the volume, money lost?
I don't. Yeah, I don't know. I really, I don't. I haven't looked at those numbers.
Mm-hmm.
So I don't feel like I feel like any number I gave you would be just a stab in the dark. I don't really feel qualified to answer that.
Yeah. Thanks.
So how do you currently perform data quality improvement in your practical experiences?
Yeah, there are. A lot of it is done through the specific programs. So, the hospital program will oversee their providers' data quality, and behavioral health will oversee theirs. So, it's not all standardized. It depends on the program. Mm-hmm. But we have place for making changes to MLIS. You have to submit basically what's called a policy instruction statement, which requires sign off from at the supervisory level, where you would, that's how you would go about making a change to a provider's file or something like that. So if you see a provider, they've got, maybe they're an individual rendering provider, but they've got a tax ID listed, and the tax ID belongs to their group. Well, that shouldn't be in their enrollment file. That should be in the group's enrollment file. So sometimes you'll find a whole cluster of providers that were enrolled, keyed incorrectly like that. So from time to time, we'll do data cleanups where, someone will have to go through lists and sort of verify what the correct data should be, and then, write them all up into a spreadsheet and send them downstairs to be keyed. So it's kind of it's an ongoing process. There isn't necessarily one way of doing it, but it's some of it is done through policy and compliance through my department. Some of it's done at the individual program level.
So is there any standard approaches or processes that are documented or?
See. I would say, from my experience, it's been not very standardized.
So it's mostly based on different
sort of like
project.
a problem comes up, and then you sort of decide how much of a cleanup do we want to do? How long is this cleanup going to take, and is it worth it? Like, is this cleanup affecting claim payments? Is it affecting like other programs, other areas? And so there's always more data cleanup that we could do, and a lot of times it's just a matter of prioritizing it. There are data cleanups that I've had to do in the past with regard to so providers have to revalidate with us every 5 years. They basically have to re-enroll. So if you enroll today, then you're okay for 5 years. Then 5 years later, you've got to come back again, send us your sort of revalidation application to let us know everything's still fine, your license is up to date, get rescreened, things like that. So we haven't had good data integrity with the revalidation date. It's a field in MLIS, and so we've been working on cleaning that up. And that, I know that there was really no process in place for that when I was working on it. It just was, had to do some data polls, see which providers had a revalidation date listed, which ones didn't, of the ones that didn't, which ones should, and then, should have had it keyed in, and then writing up, sort of going through provider type by provider type to figure out what changes we should make in LMIS, and then also if providers didn't have revalidated, it truly hadn't revalidated, not just that it wasn't recorded, but if they actually hadn't done it, then we would have to reach out to them, and they didn't respond again, suspend them or terminate them. So sometimes the data cleanup, in the data cleanup process, you find other issues like, this provider should have been terminated last year. It's usually not as simple as just making the changes in the data itself. It oftentimes actually affects how the program interfaces with providers and provider status.
Yeah.
Helpful?
Yeah, sure. Thank you. So what are the most important and recurring day-to-day problems associated with data quality improvement according to your experiences, and what causes those problems?
I would say lack of missing provider information. So if we don't have claims that don't contain the data elements that they're supposed to contain, and that's something that we are, like I mentioned before, that we're working on improving to make sure that we're in compliance with the federal rules surrounding those missing pieces of data. And I think all right, give me 1 second. Yeah, I would just say, in general, the lack of standardization of how data is recorded. I mentioned the name field. If you don't have if you've got people keying data and everyone's doing it a different way, then you're not going to have good, the utilization of that data is going to be very difficult. I mean, there are certain data issues that are easy to deal with, like, okay, you get a list and they're all missing leading zeros. Well, you can usually tell when that's the case. But sometimes you'll get a list of providers and some of the dates of birth aren't filled in. Or they're populated, but they're populated with a dummy number. And then you got to sort of determine, okay, what's a real date of birth and what's not, right? That stuff is really time consuming.
Yeah. Do you think the user training can be helpful to standardize the data input?
Yes. I mean, it's probably one of the single biggest issues is just lack of standard operating procedures.
Yeah. Thank you.
Which is something that we're working on.
Yeah. Then can you tell us about the most time-consuming tasks in the process of data quality improvement?
Sorry, say that again?
Can you tell us the most time-consuming tasks when you improve the quality of data?
Based on what I've worked on, I mean, I think it's probably, I think the most time-consuming stuff is like where you have fields that aren't, like I said, that aren't standardized in any way. I think, I'm trying to think of a specific example that would be helpful. On the audit stuff, sometimes the data that we have to provide sort of the entire universe of claims data for the entire year to the auditors, right? And they use that data in their statistical analysis to pull a sample of what claims claims they want to audit us on. And even though we're providing them with the data to begin with, the way that they then go and use the data and sort of give it back to us isn't always clear and helpful. So, I mean, they might say, you know, they'll assign every claim an ID number, and on a certain number of claims, they'll ask for, you know, verification of required screenings. On a certain number of claims, they'll ask us to go for a medical record. They'll request a medical record from the provider, and then we have to follow up with the provider to get it. And on some claims, they'll ask for eligibility documentation. And, you know, it's very time-consuming to sort of go through and then pull out each of the specific data elements that you need for each different type of request. So go for this type of request, we need the recipient ID, the dates that they were covered, and, you know, their maybe some demographic information to see what coverage group they should have been in. And then for other types of requests, you need to see what type of service this was so that we know what type of medical record to get from the provider. And for another one, we'll need to see, okay, for this, we need the provider's NPI and their name so that we can check that they were properly screened. And all of that data is available, but it's not presented to us the requests don't come, you know, sort of with all of those elements in one place necessarily. So that is a big requirement of being responsive to those audits and keeping track of what you've actually done so that they can't come back to you later and say that you didn't do something that you did. That's just, it's time consuming. I mean, you have to, even when you have good data, if it's not presented well, or if it's not, you know, presented in a way where it's all centralized, then, you know, you've got to build a big spreadsheet that sort of accounts for all of the different things that you want to be able to do. So even when there's good data, I mean, I think, you know, just having it in a way that is usable, getting the data into a usable format is a time-consuming process.
Thanks.
Yeah, thank you. Then when it also comes to the cost, what are the most costly tasks when you improve data quality?
Probably procurement costs. I mean, for instance, in order to, I mean, the new provider enrollment system that we are working on now, I mean, that's a multi-million-dollar contract. I don't know the exact amount of it, but it's, you know, that's a big cost. You know, we don't have, like I said, we have an old system. We have an old MOAS system. It's not, it doesn't allow us to do a lot. There are a lot of things that we can't do in-house, even if we wanted to. You know, we have a lot of vendors that we work with that are, some of which are quite good, and have more sophisticated data management programs, better software, and they're, you know, they're more specialized. For instance, our behavioral health ASO, Administrative Service Organization, is Beacon Health Options. So they pay for all of our behavioral health claims. Contract that out to them because they're a carve out outside of our managed care system, handled separately. And their system can account for more than ours can. It's, you know, it's where the authorizations happen. It can because it predates email.
Yeah,
So,
understandable.
so we have to, we have a workaround for that. We have to put email addresses into the remarks field. So that's a fun little aside that you can include if you want to. The upshot is we have to pay a lot of money to third-party vendors in order to do a lot of this stuff.
Mm-hmm.
Our system just isn't equipped to do all of the all of the complicated claims editing that is required for pharmacy and for dental and for there's just a lot of different types of services that we have to contract out.
Mm-hmm.
It costs millions.
Yeah, thank you. So is there a certain number of amount of money that's spent for the third party?
There is, but I don't know it.
Okay.
I don't know.
Yeah.
But I don't work on the contract. I'm not a contract person.
Mm-hmm.
Excuse me. So I don't have that info.
Mm-hmm. Okay, then is there any communication or collaboration difficulties in the data quality improvement activities? Can you give some specific examples?
Yeah, I mean, when you want to make a change, even if it's an improvement, it's not that simple because someone else might be using the data in a different way. For example, so our managed care organizations pay for a lot of services, right? Medicaid, Maryland Medicaid I think it's about 80% managed care. So in other words, we pay a managed care organization to assume the care of the patient, right? We pay, for instance, one of our managed care organizations is Amerigroup. So instead of paying the doctor for a fee-for-service basis, we would pay Amerigroup a capitated rate, every month to cover one of our recipients. We pay them that every month, regardless of whether or not the recipient uses services, right? Mm-hmm. And then if they go and see the doctor, then Amerigroup pays the doctor. But from the state's perspective, it's all capitated. Okay. So the MCOs we get the data on the encounters from the MCOs sent over to us each month. I think it's on a monthly basis. Maybe it's more frequent than that, but they send us the encounter data for their patient population, and for certain types of providers, they would, like I mentioned before, the billing provider as opposed to the rendering provider. So they have to, when they're reporting their encounter data to us, in order for us to pay the capitation rates correctly, they have to follow the system logic of what data elements, what to report, like which providers, NPIs to report, and sometimes it actually won't work for them to report the rendering provider. So, for instance, federally qualified health centers, FQHCs, when they're reporting their encounter data, they're not supposed to actually submit the rendering provider information to us, otherwise the system won't work. So it seems like, okay, that would be good information to have, but actually, in order to capture that information, it would require a whole host of system changes that would take a long time. So it might seem like, oh, that, someone looking at it from the outside might say, oh, that's something that we should be doing. But if you actually talk to the system staff, who actually have to program the logic that determines what capitation payments get paid, then it's not that simple. What you do in your department, affects someone else in their department. And, even if it would be improving the data, you can't do it without sort of getting everybody on board and making sure that the system, it won't affect someone's payments in an adverse way. It's just such a complicated system that, you open a window and then don't know what's going to happen. So there are a lot of cooks, a lot of people have to be involved in every little change. So that's one of the reasons why we can't change it all at once.
So Ben, actually, I have some relevant piece of information and a question to ask about that. Ili actually passed her proposal exam for PhD today, and one of the questions that was brought up was, okay, but so we were talking about setting up business rules and then converting them to basically formal specifications that are applied on the data to detect problems. But one question was, what happens if, for example, there are organizational conflicts or different expectations on the business rules even, right? So do you think this is actually something manageable if people talk with each other through the tools that we develop? If those things surface, do you think they can come to an agreement, or we shouldn't be too hopeful about that?
No, I think it's on the whole, it actually, on the whole, it's all very manageable. When you look at the volume of claims that we process, it's pretty amazing, and most of it gets paid correctly.
Mm-hmm.
So when there are conflicting business rules, as there sometimes are, that's just the business of governing. You just got to figure out, what's the best way to set it up so that it works the best. And it's an ongoing process to,
mm-hmm.
get everyone to agree. But on the whole, I think it actually works quite well. In spite of all the system limitations, it's just, it's an ongoing, it just takes a lot of work and takes a lot of people. But I think that on the whole, it's actually very impressive that, how often it works correctly.
Mm-hmm. Well, great then. Thanks for this hopeful answer. because yeah, you have a point. Overall, even in this setting, it still works, right? So there's an opportunity to make this better, and if those conflicts actually are surfacing, then there's a better opportunity to communicate about them and resolve them.
Right, and I think that it's one of the reasons why, even though some of these federal audits and, even though they're a challenge to the state and that they're really costly and require a lot of hours of work and can lead to takebacks, they do serve a purpose, because they require us to look at this stuff and say, okay, we've never been doing this, but now we have to. So, in that process, you find, oh, wow, maybe we shouldn't be paying for that. Or, why, these providers, they really shouldn't be enrolled with us. So there's a point to all of it.
Mm-hmm.
I think it's just, it's an ongoing process to the system to where we want it to be, because of all the challenges that I've mentioned. But yeah, it's at the end of the day, people go to the doctor and their claims get paid.
Mm-hmm.
So
yeah.
Yeah, thank you. So according to your experiences, are there other similar organizations that has a better data quality improvement mechanisms?
I think that, I've never worked in another healthcare organization. I've worked for Maryland Medicaid for a couple of years, and other workplaces other places I've worked, the data is just, the data sets are so much smaller and simpler. So I haven't had any direct contact with, to the extent that I have here. I don't have a lot to compare it to. But I do think that there are plenty of organizations, healthcare and otherwise, that have just more sophisticated IT systems than we do. It's, a lot of our data quality, a lot of the data that we rely on is crosswalked, because we don't necessarily, we don't have the fields in LMIS. We don't have the, like for instance, when we switched from ICD-9 to ICD-10, we basically had to come up with a whole system crosswalk to map ICD-9 claims to ICD-9 diagnosis codes to ICD-10 diagnosis codes, because our system can't accommodate the characters, can't accommodate the amount of data that you need for an ICD-10 code. So that's, an expensive and time-consuming workaround, but we had to do it. If we had a lot more money, then we could have just gotten a new system, but we were constrained by the political and economic realities that the state faces. So I would say that, I'm sure that there are plenty of organizations, and I think that our MCOs, I guess is that they all have IT systems that are a bit more up to date, modern than we do. But that's just, like I said, I don't have a lot of firsthand experience with other healthcare organizations.
It would be interesting to look at the finance domain and how they do it. They have more resources, and maybe their data is also simpler. At least you can think about it in more concrete ways.
Right. I think that, every industry sort of has its own, its own elements that they prioritize, right? We're able to do quite a lot with the system that we have, but it is a real limitation.
So thank you very much, Ben. We got extremely useful feedback, and I look at my notes, there's a whole bunch of information, even simple things like, for example, you mentioned expired data set, data items, or usable format for the data, which didn't come up in the previous interview. So we'll we'll transcribe the interview. This is something we do with all of the interviews, and then we have basically qualitative data methods to tag the transcripts and consolidate the data items. So our students are taking qualitative methodology classes to do this, and we'll be happy to keep in touch and keep you updated about our findings. So we are currently talking with others in MDH as well, and also developing software tools. Yeah.
Great. Well, please stay in touch. Let me know how it's going. And if there's anything else I can clarify, then please feel free to reach out.
Great. Thank you. Have a nice day.
Okay. Thank you. Thank you very much.
Bye-bye.
So, and also, is it up here, the numbers? 7.
Hello, this is Ryan.
Hi Ryan, this is Ganesh Guru from the Department of Information Systems at UMBC.
Hello, Ryan. This is Yili.
How are you?
Hey, good. How are you doing?
Good. So I hope you made it safely to your office this morning.
I did. I hope you guys did too.
Yeah. So thank you very much for participating in the interview. So we have a number of questions. I believe you received them. So the purpose is really to get rich contextual data, qualitative data that we'll collect about the data quality improvement and how it can be made better. As you may have heard, we under a research project, we've been developing some approaches, techniques, and software tools to improve the quality of data at MDH. So most of the questions are not any type of sensitive questions, but if you think you want to skip a question, feel free to do so. So to start with, what is your role in Maryland Department of Health and how is it related to health data?
All right, so I'm on the Health IT/Business Intelligence team. So my role, I kind of have different duties day to day, but I'm one of the folks that spend a lot of time on the local databases for different departments, whether it's developing them or enhancing them. Specifically the Access databases. And then I also just work on a previous project. I worked on a data pull from our major database that we use statewide.
Great.
Yeah.
So I remember you were also related to EMIP somehow.
Yes.
Yeah, so you were in our focus group meeting, right?
Yes. Yeah.
Thank you very much for that as well. So you are basically fulfilling a number of responsibilities, it seems, but you have strong connections with data. So in our research, we define a term called data defect. So defect is actually well known in the software community, or a bug. But data defect refers to a discrepancy between the actual and expected state of a data item. So to start with, could you give us an example of a very memorable or striking kind of data defect that you have encountered, maybe in terms of its implications, its effect?
Yeah, so an often problem is when it comes to the information we have with providers, just given circumstances of a provider moving, or even the billing codes that we use over time as things change. There's not really a wide-reaching programmatic change that happens to providers. So, and oftentimes you'll see a provider with the wrong address, or even a wrong billing procedure code, just because things haven't necessarily updated yet. That makes sense. So yes. I would say that is one thing I've seen.
Great. So Ely is actually has developed some tools with other students here to hopefully automatically detect those problems in the future. Maybe you heard about it from David. So defects, these type of problems with the data detracts from its quality, and we can say that higher number of data defects is associated with lower data quality and vice versa. So I was wondering, through which mechanisms and how do you realize or know about data quality problems? How do they come to surface, basically?
Well, in my role, a lot of them are brought to my attention either from people in other departments that were working with a provider and noticed an issue. Also, we've done our own project where we kind of do data polls, and we'll throw them in an Excel sheet and produce formulas that will tell us which ones are if there's some codes that are incorrect. And as well as in the Access as well. There's some databases for it. But yeah, that's basically what I know on my end.
So the others who tell you about data problems, who are they and which departments do they work for? So
I would say, basically they're kind of but in OHS, so the Office of Health Services, like all together. So whether one example is the Healthy Kids Dental Program, which I'm probably butchering the actual title because I don't work with them too often, but I did actually go speak with them last week on some issues that they had. So yeah, it just depends. It's kind of like we have communication with just about every other department and the overall Office of Health Services. So it just depends. But usually it would be like the chief individual or one of their assistants.
So the chief individual or his or her assistant calls you up when there are problems with data.
Yeah.
Okay, great. So this data quality improvement basically activity, which it should ideally take place in any organization now, and I think you're the one doing a lot of work in MDH. So it's basically identifying data defects or detecting them, and then tracking them to their resolution to ensure that the data is corrected. So to what extent do you think data quality improvement is necessary, and why would your organization need it?
So it's, I guess for us, it's super necessary. Our division kind of fights fraud. So in that case, we need the most up to date and accurate information. So whether it's because there's different types of data that we deal with, whether it's just representative data, whether it's address, names, and whatnot, but also the billing side and the cash flow side. We want to make sure all that is correct and accurate as well within our databases. So for us, we do our best to kind of make sure that data quality is there, so can kind of reach our goals. But I guess in our roles, we every day try to come up with whether it's EMIP or just even the local the access databases. We continue to try to keep up with the data.
Yeah. So if I hear you correctly, there are basically needs, operational needs, right? So basically day-to-day operations may be affected from data quality. So how about with the increasing volume of data everywhere, and now there is more push towards data analytics in any organization. I think yours is one of them as well. Do you think, to make better programs in the future or plan better interventions, people want to use data, but they cannot use it because of these problems? I mean, in addition to the operational needs you describe, you fight with fraud and,
Yeah. I think different types of software definitely help with the operational needs and flow. Yeah.
So how about the decision-making side? Or do you think data quality can affect or detracts from the quality of decision-making now?
So yeah, I think in terms of decision making, I think the data quality, as it improves, it definitely helps guide the decision making process. The one thing I have noticed though is sometimes just numbers alone don't really capture the full picture of what's going on behind our beyond our walls or in our building. Just when you when you're in contact with a medical provider, all you have is the data that you have on your side, and you're left to using just that to kind of make that decision how you're going to interact with that provider. So
yeah, of course, yeah. So what are the most time-consuming issues occurring because of data quality problems? And I'm not talking about the data quality improvement itself, in the field, what are the time-consuming issues?
Gotcha. So the time-consuming issues could be sometimes there could be a miscommunication because we're looking at different data. And kind of going back, whether it's miscommunication, I feel like miscommunication with an external actor or individual would be more time consuming because you have to figure out, what went wrong. Whereas internally, it might not be as time consuming, but I would say that would be one issue that I've seen. But that's all yeah.
So I was wondering if there are, for example, basically activities that are repeated because the data is not.
That's what you said.
Yeah.
Yeah. So one part of my job too is to process requests from different chiefs of different divisions to actually update the data. And we've implemented a new ePrep system to help solve the issue because it allows the actual provider to just log in their own profile and update their address in real time. But that's something that we continue to do, and that's part of my job is to help keep up with the data quality issues. That makes sense. So yeah.
Generally speaking, time-consuming problems are also consuming dollars, but also sometimes it's useful to specifically think about dollars because, there may be some more costly things that are problems that are caused by bad data. So if we take that perspective, which is the cost perspective, what are the most costly issues occurring because of data quality improvement problems? Data quality problems.
I would say that I don't have a good answer for that one. But like you said, obviously, having different employees throughout the organization kind of figure out data quality issues over and over again, it is kind of costly. And I'm pretty sure that you could kind of add up dollar amounts for different areas, but I don't really have a background or a knowledge base on that.
So for example, you mentioned fraud, right? So do we, for example, have rough idea about what's the cost of something not detected, or for example, what is the lost opportunity of not detecting fraud? And do you think people thought about those?
Yeah. So actually, individuals on other teams would have better numbers to give. And I wouldn't give an estimate because I'm really not. I know it's a pretty high number, but I wouldn't ballpark across the different groups that I work with. But yeah, I know as the data is more accurate, it's much easier to catch instances of fraud, or even if it's not fraud, but issues where we might actually accidentally overpay or something on a claim or whatnot.
Yeah. I actually asked Jesse, and Jesse, I believe, didn't have very specific numbers either, right? So, by the way,
I would say Jesse would be the perfect person to ask. But yeah.
By the way, I realized that Yili didn't have any opportunity to ask questions. Sorry, I'm on a roll this morning, so dropping off kids and then coming here. So, okay, very good conversation. So I'll just let Yili ask the rest of the questions. Sorry, go ahead.
Sure. Hi, Ryan. So can you tell us how do you currently perform data quality improvement? Is there any approaches, steps, or tools?
Okay, so basically, one thing is just general communication with providers that say this is there's something wrong, either with me trying to process a claim through you guys and there's no money flow, then we try to figure out what's going on. So we'll see if there's a data issue there. So general communication with providers outside kind of helps track the issues, which is quite hard because of the amount of providers in the state of Maryland and just the general amount of information coming from each provider. So that's a very loose or accurate wide net of catching data issues. We also do have our own like smaller databases to try to figure out different parts of the data. So whether it's procedural codes that we're like able to like mark down for a provider, we'll try to make sure those are accurate. And we sometimes will do a comparison to like the NPI system because that tends to be more accurate, because I think that's like a yearly update in terms of like getting information from providers, but I could be wrong. Yeah, so like we do have our smaller projects where we'll use like an Access database or an Excel spreadsheet and implement formulas to kind of figure out what's going on and pinpoint which providers might have like data issues and which ones don't.
Great. Is there any documents about the guides of those approaches?
I would say a good question. So I don't. I would say kind of, but they're framed in a different way, more as like a quality assurance as opposed to. I mean, I suppose I think in the ones that I use, like I've made an SOP for one of the databases that I use, but it's more for interacting with the database as opposed to like big like. If that makes sense.
Great.
Yeah.
Thank you. Then, what are the most important and recurring day-to-day problems associated with data quality improvement, according to your experiences?
I think the larger problems would be when a provider is unnecessarily like suspended for like a data issue, which is kind of rare, but like sometimes if something's missing in our database, sometimes like we will like suspend like payments to a provider. Like that's a rare, like a smaller issue, but it's more so there's more unnecessary communication between us and providers because of data quality issues at times, which means it like just takes up more time from individual schedules that can be doing something else. So yeah.
So when it comes to the procedure that you make improvement on data, is there any day-to-day problems that you encountered with?
Wait 1 second. Day-to-day problems, I'm thinking. I would say that there's like day-to-day wise, there's not. Sorry, I'm thinking recurring day-to-day problems. It would just be the fact that like providers don't always like update us when there is something new, whether it's like the address or another update. So I think that's one of the issues that kind of brings recurring day-to-day problems, if that makes sense.
So, Ryan, you also mentioned you deal with a lot of Access databases and you sometimes write rules to detect problems in the data set. So it seems like currently, there are some approaches, but perhaps would it be accurate to say these are ad hoc? And so we are basically trying to ask what are the day-to-day recurring issues when you work on data quality improvement?
Gotcha. Okay, so I would sometimes it would just be like the communication between us and the individuals that do process like ad hoc. Yeah, and because I've only personally worked on one all the way through, and I noticed that there can be, I guess, issues with like data uniformity and different like the perspective downstairs compared to like when we're actually trying to analyze the data that is brought back up to us. Yeah, but I'm trying to think of a good way to like conceptualize. But yeah, I would say just we would in my case I had to go back and forth with the folks that ran the ad hoc because of the fact that there's not a consensus with some data uniformity, so we actually had to kind of go a roundabout way and have a few extra meetings with the programming folks to fully understand how some sets of data are formulated, and we had to like loop that back around to the actual individual that pulled the ad hoc for us to update, basically get the proper data set. So I would say in that case, the data quality and the data uniformity, it was more so the uniformity was the issue. And basically it was calls for much more communication across like us and then the programmers, and then going back to another programmer that didn't know what the other programmers were doing, if that makes sense. But yeah.
So the data uniformity may mean, for example, same data items may be referred to by using different names, and sometimes the names can mean different things to different people. So that's there are no standards. That's what you're saying.
Well, in the case that I'm talking about, it was more so so it was like in our system, in our main database system, we can pull up a screen and we can like look at the claim that was submitted by a provider, and there's different types of claims, whether they're like related to Medicare or if they're just like directly sent to us and processed straight directly through Medicaid. And sometimes they're processed differently, and the way that they are displayed in our database is different. And because we're using the old system from the 80s, sometimes you don't even know that there's a button that you should press to actually go through the complete claim. So that was the issue with my experience. So, yeah.
Thanks.
Then, what are the most costly tasks in the data quality improvement, according to your experiences?
Gotcha. I honestly wouldn't know that one. In terms of money spent on trying to fix the quality improvement, I know that we've implemented new systems like the EMIP and the ePrep, and the way I am looking at it is that's kind of where our money is going to fix the quality of the data. So I'm assuming, yeah. So I don't really know what I'm comparing it to say that it's more costly or not, if that makes sense. I'm not really sure how to answer this question.
So basically, we know that personnel time is spent. For example, David often mentions he spends a lot of time finding and fixing problems with data.
Yeah.
So we were wondering if there are other costs associated with it as well.
Gotcha. Yeah. So it would be. I think it would be like hours spent, like time spent, like you just said.
Mm-hmm.
Then also the implementing like these new new database or something to kind of help with the issue as well, if that makes sense.
Yes.
Yeah, but I'd say that's what I personally see is the hours spent ePrep that just started. Yeah.
So can you tell more specifically about the time-consuming tasks that you mentioned in data quality improvement?
Yeah, so it would be one issue I would say is depending on the provider, communicating with various providers can take a lot of time. And then on top of that, when a provider has, an assistant or something, but that provider has a lot of turnover, sometimes they don't necessarily provide the correct information. So you tend to have to double check. So the communication with providers is definitely one of the more time consuming issues. And I think that's where ePrep will and should be super beneficial in terms of hours spent, and hopefully diminishing the costs of lost hours, and then and then spending time I guess in my position, excuse me, I've spent a lot of time myself just going through different data sets to try to figure out what's wrong.
So the system you refer to is the new provider enrollment system?
Yeah. That's the new provider enrollment system that allows different providers to actually log into their own profile. Per se, I haven't actually seen it live and in person, but basically it allows a provider to log into their own system, and then they'll be able to update various bits of information, whether it's location, whether they're adding new people that work for the organization and are removing those people that work for the organization, if that makes sense.
Yeah. So I think your answers made me realize something. So this data quality improvement initiative or tools, procedures, they have an external component as well, right? So for example, we often think about this saying we are working on a collaborative organizational data quality improvement toolkit. Actually, Yili's proposal, which is this week, it has that same title, but maybe perhaps we should also include some external parties in this collaboration. Maybe they will be notified by saying their data is not correct. And do you think that is important?
Yeah, I would say so. Yeah.
So providers are then in that case the most important external. It's the most important external party.
Well, yeah, I would say there's different ways to look at it. So one way to look at it is is the information that we have, the bits of information that we have that are the same as the national registry. If there is some way to double check that, because we actually do use NPES to actually go back and forth to double check data, especially if it's a provider that's one thing is to double check to make sure we're looking at a group versus an individual. We have to go to NPES. So incorporating some way to kind of check the data versus what the federal level has is something that would be beneficial. And it cuts down on our marginal time of us reviewing different providers, if that makes sense.
Yeah, so not only external, basically human agents, but also some external other systems, basically computer systems. Okay, so these are good points, very good points. Thanks. Go ahead.
Then what are the communication or collaboration difficulties in data quality improvement activities? I believe the communication with provider is one example. So
I would say, and because I'm not I don't have a direct hand in the new the ePrep system. I would say that, and it just started last month, I think. I think they're trying to work out the different kinks and getting the ePrep system up and running. And I know that there have been different difficulties, which I'm not familiar with, so I couldn't actually list the different difficulties. But I think I was able to bore you in our EMIP session. But one thing I did notice is sometimes having the database kind of keep up with the demand of both the providers and our side internally. So I would say, let me make sure I'm asking answering the right question. But yeah, so I would say kind of keep having our systems kind of keep up with whether we have a new piece of data that we're going to start holding on to because of a federal policy or whatnot. Having I would say having our systems being able to kind of keep up with this demand. Obviously, there's always going to be a lag time, but to kind of diminish that lag time is always helpful.
Yeah. Is there any collaboration difficulties within your group or your team when you do data quality improvement activities?
Yeah, so sometimes there might be a mixed distribution of knowledge in terms of how to interact with information coming from our statewide database. But otherwise, I would say I haven't really seen much issue in collaboration, I guess, with people on my team. However, because we are such a large office, I know that sometimes there can be a lag in communication between different parts of the divisions. But yeah.
Great, thanks. So in data quality improvement, what current activity can be possibly eliminated or possibly merged? Why would this be useful?
Is there anything unnecessary that you're doing? Maybe it's better if you don't do it and eliminate it.
I get what you're saying. I would say I don't think there's anything that we would eliminate. I don't think we're doing anything extra in terms of processes. Yeah, so I do think that fortunately, I guess the folks that I work under have definitely come up with good processes to kind of keep a good steady flow between different jobs.
Yeah, thanks. Then are there other similar organizations with better data quality improvement mechanisms?
Actually, no, I don't know of any off the top of my head.
Yeah.
Yeah.
Thanks. I think we are.
Yeah, so thank you. So that brings us to the end. And do you have any questions or comments for us?
Not at the moment.
Well, okay, thank you very much for participating in the interview. So we'll keep you updated, and you always seem to give very insightful responses to our questions, and I think we definitely got something useful from this. And I'm sure we'll be in touch either through David or Joe. So we'll probably email you with the follow-up transcripts and reports.
Okay, cool. All right, thank you so much.
Thank you.
Thank
Have a
you.
nice day. Bye-bye.
All right, have a good day. Bye.